Welcome, everybody. We are starting the webinar. I'm bringing on the first speaker in about 1 minute's time. And it's just a few little things that there's people coming in. We have two audiences for this event. Half of the audience is on Zoom webinars, and half of the audience is on LinkedIn Live. Everyone's welcome. When this webinar ends, we're going to a 60-minute after party where we're bringing on members of the audience to speak. The after party is only in Zoom, and we're going to be posting the Zoom link in the chat. And the reason why the after party is on Zoom only is because if you're on LinkedIn Live, we can't turn on your camera. We can't bring you on the screen. So that is enough for me. This event's a bit different. We have one opening speaker. Well, we have basically one speaker who's like a conventional panelist, and his name is Andy Miner. He is going to set the table with a presentation, and then we're going to the use cases. And without further ado, from me, let's see, Andy, welcome.
Hi.
And Andy's co-chair of Open EHR UK, health data interoperability expert. And he gave a talk about a month ago, and I've already told him this. It was one of the best. I think it was the best interoperability talk I've ever heard. It's like, come over here. We got to get you on to open this event. And so have I done a good job of introducing you, Andy?
You've done a great job, Jose. Thank you very much. Yeah, it's great to be here.
I think you can take it away from here.
Okay. Let me just share my slides. So, hi everyone, and thank you for everyone joining today. It's a real pleasure to open this session, particularly because the topics of new models of care is becoming one of the most important conversations happening in healthcare right now. So across the world, healthcare systems are under enormous pressure. Demand continues to grow, populations are aging, chronic disease is increasing, and at the same time, workforce shortages are becoming more acute. So the question we face is not simply how to digitize healthcare. The real question is, how do we redesign healthcare itself for the next generation? And the discussion we're having today about new models of care sits right at the heart of that challenge. For most of the last century, healthcare has been built around hospitals. Patients come into the system when something goes wrong. They receive treatment, then they leave. But increasingly, we're seeing a shift away from the episodic hospital-centric model. Care is moving into communities. Care is moving into people's homes. And care is becoming far more about continuous, coordinated, and preventative. We see this in things like virtual wards, remote monitoring, integrated care systems, population health management. These are not just digital initiatives. They represent a fundamentally different way of organizing care. So Rachel Dunscombe, who's a hero of mine, she was the CEO of Open Air International, and she's now gone on to become the CEO of HL7 International. She made a really good, important point around this. Digital transformation by itself is not the goal. The goal is better care. Technology is simply the enabler. If we get this right, digital tools allow us to deliver care closer to the patient, earlier in the disease pathway, and in ways that make far better use of clinical expertise. But achieving that requires us to rethink not just the technology we use, but how the entire system operates. So here's some examples of new models of care. I'd talked about them previously, but the direction of travel is clear. Care is moving from hospitals into homes and communities, and this creates an entirely new information challenge. As care becomes more distributed, something very important changes. Information has to move. In the old model, most information stayed inside a single hospital system. But in these new care models, a patient may interact with primary care, community services, hospital specialists, remote monitoring platforms, digital therapeutics, and patient apps. If information doesn't move seamlessly between these settings, clinicians cannot see the full picture. And when clinicians cannot see the full picture, care becomes fragmented. So one of the biggest challenges in enabling new models of care is actually information flow. Alongside these changes, we're also seeing the rapid emergence of artificial intelligence in healthcare. AI is often talked about as a technical revolution, but in reality, its greatest impact in healthcare may be as a force multiplier for clinicians. AI can help identify patterns across huge volumes of data. It can support clinical decision making. It can detect deterioration earlier. It can automate administrative tasks that currently consume enormous amounts of clinical time. In other words, AI allows healthcare systems to shift from reactive care to proactive care. And this is exactly what many of these new models of care depend upon. But AI depends on data. AI is only as powerful as the data it can see. Today, healthcare data is often fragmented across many different systems. It's stored in different formats. It's recorded differently by different organizations. And in many cases, it's effectively locked inside individual applications. That fragmentation makes it extremely difficult to build reliable AI systems. It also makes it difficult for clinicians to see the full longitudinal picture of a patient's health. So while AI is generating enormous excitement, the real limiting factor is not the algorithms, it's the data architecture beneath them. The way healthcare data is structured will fundamentally shape what is possible over the next decade. If data remains fragmented, then innovation will remain fragmented. We will continue to see isolated pilots, local solutions, and systems that struggle to scale. But if we move towards data that is structured, interoperable, longitudinal, and governed through open standards, then something very different becomes possible. We start to create a platform where innovation can happen much more rapidly and safely, and where new models of care can evolve without needing to rebuild the entire digital infrastructure every time. When that kind of data foundation exists, healthcare stops being unorganized around individual systems. Instead, it becomes an ecosystem. You can have many different services working together: clinical systems, patient apps, remote monitoring tools, AI decision support, population health analytics. Each of these services can innovate independently, but they can all operate on top of the same shared data foundation. This is the kind of architecture that allows healthcare to become more adaptive, more collaborative, and ultimately more patient-centered. So as we move into the rest of today's discussions, I would encourage you to listen for three key themes. First, how models of care themselves are changing. Second, how information needs to flow across organizations and care settings. And third, how technologies like AI can support clinicians and patients within those new models. Because ultimately, the transformation we are talking about today is not just digital transformation. It's the redesign of healthcare itself. If we get this right, the prize is enormous. We can build healthcare systems that are more proactive, more personalized, more sustainable, and better for both patients and clinicians. Technology alone will not deliver that, but the right digital foundations can make it possible. Thank you very much, and I look forward to the discussions that follow.
Thanks, Andy. And thank you for delivering that. That set the table for us not quite nicely. And I'm going to bring on our first use case. So Andy's handed out the lightsabers, and let's see, remove, add. Hello.
I'm Valerie. I'm Valerie Peterson. I'm the founder of Nest, Mental Health Innovation Foundation. And today I'm going to present you the latest technology advancement in mental health care. And I'm going to share the screen now so you can follow along with me. Can everybody see?
Yes, we can.
Okay, great. So the topic will be innovation in mental health technology. Of course, there is a problem in mental health care right now. There's a mental health crisis, and care is mostly reactive and not proactive, as Andy already mentioned before me. The data that's available is mainly consisting out of short sessions combined with self-reports. And there are huge gaps between appointments, for example, therapy appointments. So many people already use wearable devices to track their sleep, activity, heart rates, and this data is siloed and it's not integrated yet into mental health care. So there's actually a big opportunity here to use the continuous data for earlier and more continuous support. So this is my first use case based on depression relapse. Because before a relapse in depression, we usually see a sleep and activity change. And wearables can see these patterns as well, as they can drift from a personal baseline. Examples could be Wyza, which is a company focusing on a mental health application using health data from wearables. And the potential flow could look like detecting a risk pattern, because there is a variation from the personal baseline. Then they offer an in-app support and coping tools, and could also suggest contact with a clinician. So the next use case I would love to discuss is a bipolar mood prediction, because in bipolar we see that there are huge shifts between depressive states and manic states. And signals could be derived from HRV, heart rate, or fragmented sleep, which can also be linked to wearable devices. An example could be In the Zone, a really interesting company that actually facilitates peer-to-peer support between bipolar patients. And it could be very interesting if clinicians also have data from these apps to prevent or to anticipate episodes and facilitate continuous monitoring of patients. Another example is stress and anxiety, because this is a more moderate effect of mental health issues. The stress shows up in the body first, and most of the time after that, the awareness arises in the patient itself or the person itself. And signals could be a change in heart rate or a worse sleep quality. And why this is important, because we could use instant feedback for the user. You could, like in the moment, you could suggest like, hey, your sleep is not doing well. Try this and this. Or understand triggers over time while the device gets to know you and your baseline better. Here you can also see an example of human-computer interactions and voice. So devices such as mobile phones can already sense how people are interacting with their phones, and based on that, they can kind of predict their mental state. In the top image, you can see some examples of this. So the key message from this slide would be going from weekly check-ins or maybe even once a month with a therapist, you could go to 24/7 support using a device like this, if well integrated. So here are some real life examples. This category is already taking shape, and companies are actively playing into this new technology. You have the nightmare related device. You have clinically validated interventions for cognition. and prescription digital therapeutics as well. I think it's super interesting. I fully support all innovation happening in this space if it facilitates earlier intervention. So something about us, we are a foundation, community, and a platform for mental health innovation. We share resources, latest industry updates, and champion meaningful innovation in mental health care, all to accelerate the industry and vouch for a more safe and transparent deployment of digital mental health tools. Because alongside with innovation, safety is also a very important topic that's often overlooked by founders. So I feel like the future of continuous care could be powered by wearables and data. There are definitely some benefits to this, like earlier detection, real-time insight, and also personalized support. And if you're working in this space or if you want to collaborate, don't hesitate to send me a message. I'd love to meet you, learn more about your digital solution. And yeah, that's basically it. Thank you so much for listening.
Hi, Valerie.
Thank you, Valerie. I'm going to put your. Just go ahead. Go ahead.
Yeah. So, can you hear me?
Yes.
Yeah. So it's amazing. I think the work you are doing is so important. One of the area is there are so much with the mental health. A lot of people cannot, once you get to a situation where you are already, spiraling down the thing, it is so late and you are trying to recover from them. And on one side, from a patient point of view, how do you get them earlier and get them, get out of these episodes, as well as from a financial point of view, in my opinion, prevention helps a lot better than having somebody, institutionalized or go some part of it and everything. So it's actually, this is the best way of doing it. So how do you see the privacy side of it? I mean, I see some value. How are you guys looking at it from a privacy, from individual point of view, family point of view, community point of view, and all that? What are you seeing there?
Yeah, what I am seeing is that for example, the app I mentioned in the zone, the bipolar support app, people get to choose their own tribe, so they can actively choose with whom they want to share their personal information and their current state. So they can choose like a safe network of people that they are comfortable with sharing their story or their state of mind. And also, I think it's really important for these tools to be clinically validated. Many founders actively work with universities to test the safety of their product. And there are also guidelines that are being created right now for digital mental health tools, also to do a self-check as a founder and also to do certification, for example, as an auditor.
No, I think that is very important. I think we have seen some few cases, but that get, amplified, some bad messaging come out of LLM or something, and
Yes.
some people become, thrown into it. But I think you are absolutely right that the community, the trusted community they build, and that, tool gives. Thank you.
Thank you.
You're welcome.
Thank you so much, Valerie. Can you stay for the after party?
Yeah, I can stay.
Thank you. And I'm going to bring on our next speaker, Martina. And there you are.
There I am. And
Welcome.
thank you.
And I'm wondering if you could introduce yourself and the work you're doing, and you're going to share a presentation with us.
Is that visible on screen, or am I doing my usual stunt?
We're seeing a slide, and then we're seeing a few slides.
Okay, so that should ideally be just one. Okay, let's try this one. Okay, is this
There
better?
we go. That's it.
Okay, I'm just trying to introduce this as this really charming, slightly haphazard, but in any case, my name is Martina, and I'm the founder of Viatitude Health. And quite early stage, even though I will proudly present you very soon with the MVP that I built on Sunday after months of battling with various different developers who did not understand what I mean. And now with the amazing world of vibe coding, suddenly everything's possible. So here we are. Viatitude Health will be an app that will give the user tailored guidance, personalized guidance on food and lifestyle choices to make in order to improve their brain health now and decrease their risk for Alzheimer's disease later in life. So that's really the elevator pitch. Everything is evidence-based. Everything's based on published scientific data that has been peer-reviewed, so high quality. And just one sentence about me and my motivation. It's by now 10 years ago, I was very ill. I have an autoimmune neurodegenerative disease, and I was for a long time in a very dark place. My brain did not work anymore, and after the brain scan, I didn't actually get any drugs. The neurologist didn't really believe in drugs. And that was, in hindsight, the luckiest thing that ever happened to me, because that really forced me down the route of researching, trying out everything, just getting back to life. And on that journey, so I don't have a medical background, so that was very much driven by, with my declining cognition, reading stuff on PubMed, reading the abstract, the conclusion, trying to figure out, does that resonate with me? And then simply trying stuff out. Vitamin D, magnesium, whatever it was. But that's really my personal journey. And on that journey, I came across a very large body of evidence that was very specifically talking about the incredible power of food and lifestyle choices or interventions in preventing Alzheimer's disease. So a lot of papers talk about 40% more. Some more outlier papers talk about a lot higher percentages. But in any case, the data is very, very solid and very clear that our daily choices really make up our brain health. And I figured, well, all that data is available. It's not really accessible because who's going to go to PubMed and go like, oh, let me real quick just double check and read 1,000 papers. And at the same time, the solution that a doctor will offer to anyone that is starting to show signs of cognitive impairment is drugs that may decrease their rate of decline for a few months, but that is not a solution. There are new drugs you probably heard about, lecanemab, aducanumab, all these drugs that are very much focused on either destroying amyloid beta plaques in the brain. There is a new generation of drugs that are addressing tau tangles. In any case, these drugs are hugely invasive, problematic, highly expensive, not a solution. At the same time, we have all this data about the food and lifestyle interventions. So, long story short, to me it was very clear all that data has to be made accessible to people in a convenient way, in a personalized way, so that people that don't have any medical background would still have a daily companion in their pocket, if you will, that tells them what they should be doing, should be avoiding in order to improve their brain health and really, for today, reducing brain fog, fatigue, whatever it might be, but also supporting their brain health in the long term. And as a side note, females make up 2/3 of Alzheimer's patients. Of course, the declining estrogen levels in menopause play a big role, it's not everything. But in my initial user test, I noticed that 40% of females didn't even finish the user test, and that was very much the paper PDF-based user test, just a very conceptual test. But they kept dropping out, and afterwards they were citing life happens. The kids, the husband, the house, the dog, the job, everything more important than they themselves are. So I realized even more important that it is very easily digestible, very convenient, personalized, because we all have moms, sisters, friends. We all want, and we ourselves, we want to keep our brains. So there you go. And you can tell it's my favorite topic, so I can talk for hours. So what I've just said, really, Alzheimer's is just a huge epidemic and no proper solution, while at the same time there's all this food and lifestyle, very high quality data available. So, and we see it in papers here in the UK. The headline, Alzheimer's is preventable with food and lifestyle, is quite common. And when you read the article, it essentially says, don't be fat, don't smoke, you'll be fine. And yes, that is a good start, but there's a little bit more to that. And very important, everybody knows the word Alzheimer's. Nobody wants to have it, to the extent that people don't even want to think about it. And so my whole mission and journey is really to go from dementia, bad, scary, to supporting brain health. And it's just the other side of the coin. So, and what I have built now, ta-da, that is now the MVP. And so fundamentally, the structure is really that a user sets up the user profile, and that is, in the full version, it's going to be on the one end, the habit questionnaire, not a medical questionnaire, it's really habits. Where do you live? How do you live? Which indicates so many factors that are relevant for brain health. Being toxicity, living in an old house might indicate mold, what is your nutrition, what are your habits, all that. And at the same time, the final version will also have APIs to all the wearables, which are really the daily indicators where health is and or where it's going. And the third point, and that is the third data source, and that is that's a business that will white label into the app, and that is analyzing users' blood tests, stool tests, and on that basis, they provide very specific interventions. So it is quite a holistic data set that the user provides to the algorithm that on that basis will provide the user with weekly guidance. And every week in that weekly guidance, so for example, the weekly topic might be support your detox pathways based on the fact that a person lives in a big city, likes to play golf. We know about the glyphosate issue on a golf course. A person likes to eat tuna, all these things that might indicate higher toxicity levels. So then the weekly guidance, the topic might be support your detox pathways. And that is broken down into 3 weekly, what I call micro tips, that will be sent as push messages with reminders, very specifically, spirulina to bind the mercury from tuna, for example, or take NAC to support your glutathione production, to improve your liver function, stuff like that. So everything very practical, very much broken down into very easy, small steps so that everybody can do that. It is all about being tangible, realistic, sustainable, never the tone of you have to. Very much the tone is depending on who the user is and how old they are. So at this stage, we're focusing 35 to 65-year-old females because that is perimenopause, menopause. That's when females know, I need to support my brain. And that is really the hook to get people interested after males feeling they're going to live forever, so they don't really care at this stage yet. When the whole app is really done, there's a placeholder. I don't know if you can see it on the screen. There it says directory and community. That will happen later. That is really a directory of services that are very much supportive of a user's personalized brain health journey. That is much more expensive, but it's a choice of the user if they want to have sessions with a functional neurologist, for example, or very specific, exercises, cognitive, physical, whatever, or the community aspect, of course, on the bottom right. The idea is there that there will be a communication tool together with the other users to exchange experiences. So that's really where we're at. You can tell I'm super excited about the MVP. It is not yet fully in a shape where I can show it to strangers and test it with strangers. I am testing it currently with friends, and that's very helpful too. And so the idea is really that this tool will be available to the world, if you will, to anyone who is actively interested in supporting their brain health. Possibly they've noticed that they are now 45 years old and possibly they forget their keys here and there. So that is really the idea. It's not something that people have to do for the rest of their lives. They can do it for a few weeks, months, pick it up again in a little while. So it's very much about the very positive, optimistic, supportive side of brain health, never the worst case scenario, everything's terrible, and it's never too late. And the last thing I'll say is I was in terrible shape. It wasn't dementia, but it was de facto the same thing. I didn't know my own PIN number anymore. I couldn't do anything anymore. Nothing made sense anymore. So I know what it's like. I know that the brain can heal because I demonstrated it to myself. And I would like the world to never be in a place where they don't remember anything anymore. And I would like the world to simply have the knowledge, understanding, and also the confidence to save their own brain. And with that, I see a raised hand.
Thank you, Martina. I'm going to, Valerie.
I would like to ask a question to Martina because
Go ahead.
This solution you're building really resonates with me because I have a parent with very early onset dementia, and he got it at just 56. So he is living in a care home now. And I was wondering whether you are planning to roll out this solution into care homes as well, or just B2C?
Well, the idea is really, it's preventative. So, and Alzheimer's plaques start to accumulate in the brain 20, 30 years before symptoms start. So it's very, very much preventative. And at this stage, the business model idea is B2B2C. So it would be a perk that a private health insurer, private life insurer, DNA testing lab, employee wellness program would give to their members, to people that are young enough to still be healthy cognitively, as we all are kind of, but that really have a reason to support their brain. But to your question, I would say it's never too late. So if somebody would be in a position to help your dad, or provide your dad with the nutrition that is ideal for brain health, there is optimism for everybody. But the further progressed we are on that journey, the harder it gets, the more it requires personal intervention. So to your question, whether I am thinking of rolling that out to care homes, I would like to roll that out to institutions where people are in their 40s, and to catch them as early as possible. Because I think one of the other speakers was saying before, prevention is so much easier than treatment and reversal of symptoms. And so that's at this minute.
We have two other questions. Fredrik, first Fredrik, then Ruben.
Thank you.
So thank you for focusing on the quality that Andy mentioned in the beginning, because that is really a big issue in the healthcare domain, health and care domain, and data at large. There is an example called the functional MRI debacle, which was discovered in 2010, fixed in 2015-16. So it's extremely important when you train your models here that they are based on correct data, recalculated data, because all of the information, not all, but I think they came up with 60% of the information was wrong. So it's a very, very touchy area. Extremely important that we get this right quickly, because as you say, preventative is the key, and preferably even preventative medicine.
Yeah, and exactly. Probably as a side note to my business, it is really data quality, exactly as you say, because anything health related is still incredibly politicized. So it is really now at a stage where we're constantly just editing everything or checking everything that the AI produces, just to make sure that it really makes sense. And that may go on like that for a little while, I have the impression, but it's really all about data quality and the quality of the guidance, and not to fall back to something that was guidance from the American Heart Association from the 80s, which back then was the gold standard, but now has been caught up by various pieces of research. And but for some reason, some pieces of quite ancient health data is still quite prominent in people's minds and ranking quite highly in various databases. So I think data quality, content quality is hugely important. I could not agree more.
Okay, I'm going to bring on and our next speaker, and
there's one more raised hand, I think.
Yeah, I had a quick one, but Jose. So the thing which I thought was actually connecting what Madna you are doing from external factors from food to behavior and all that. I was thinking about what Valerie presented at the beginning from the mental health part of it, and looking inward also. There are behavior of people, how they are doing it and what they are not doing it, or what they are afraid of, because it builds up both ways. Yeah, I mean, external factors and internal factors. To me, is there could be a link between what Valerie is building on the mental health from, building communities and all that. That can be a feeder into yours to build a holistic solution. That's what I was going to say.
Yeah, definitely. Thank you.
And can we, Martina, do you mind stop sharing the stop? Thank you.
Okay.
I'm going to bring our next speaker, Sudha. Welcome. And Sudha works in digitally enabled elders care.
Yes.
And I'm so glad that you agreed to speak, Sudha. And I've actually attended one of your webinars. I thought you weren't speaking, I don't think, but I did attend about a month ago. I don't think you guys are launched in Spain, though.
Well, we do have some presence in Europe, but more in Portugal and other, because our founder is actually from Portugal originally. But thank you, Jose, for the opportunity. I'm really excited to talk to this audience. Just to give you a little bit of background on myself, my name is Sudha Ragmi. I'm the Director of Data and AI at Nourish Care, which is a digital sort of software vendor in the care sector. We're the leading care records sort of vendor. I would almost think about it as EHR for care, really. I joined Nourish maybe slightly over a year ago with the mission of sort of enhancing our existing data and analytics capabilities, and then also adding sort of AI use cases and AI based implementations in our product suite. So AI is top of mind for me all the time. I also have interesting enough, I started my career in the US focusing on public health and healthcare systems in the US. So I bring that sort of thinking from what's working in the US, what are the trends there, and then how does that apply to healthcare systems in England, which is a bit quite different, but actually also social care systems in England. So that's my perspective, just to give you a little bit of sort of intro. Let me go and sort of talk through this. I believe you can see my screen.
Yep, we can see it.
Amazing. Let me talk about, like I said, Nourish is a social care records company. We're in the health tech space, primarily focused in the UK. We are one of the largest providers, and then we've been around for 10 years plus, right? And if you think about sorry, I'm trying to find my speaker notes, but I lost it. So bear with me.
Bear with me. You're turning British.
I am. I've lived in England for 8 years now, and I find myself hankering for a cup of tea quite a lot. So I am turning British. Sorry. This isn't working as I expected it to work. Let me try this, and please, you'll have to tell me if this doesn't work. I'm hoping you can see my entire screen now. So Nourish has 450,000 carers and support staff that use Nourish every day, and it has 18 to 20 million care records updated in the platform every day. And I wanted to give a little bit of that context before we sort of launch into the use cases and how we think about analytics and data and AI, really. Having said that, let me sort of take a step back and think about sort of data-driven intelligence in care sector. I like to always talk about take a step back and really think about sort of AI in care, right? The term AI has been around since the 1950s, but obviously it sort of blasted into everyone's consciousness at the end of 2022 when ChatGPT was launched with GPT 3.5. Obviously, AI is broader than generative AI, so I just want to call that out. For me, as I think about AI, I think about sort of almost the continuum of data, analytics, insights, and AI all together, because it's not about the techniques, it's about the opportunities and the use cases and the problems we can solve in workflows, in whether in social care or healthcare. So when you look at this sort of this continuum or diagram on screen, we go from talking about what happened to really sort of predicting and influencing outcomes, which is sort of more AI led, right? I'm going to talk through a little bit of an example of wound care management to show you how that continuum lies and where and how there is value at each stage of this journey. So descriptive analytics, where a lot of health and social care providers are really realistically sitting at still, is about analyzing historical patterns, and in this case, wound data, to understand past outcomes. So that highlights what's been happening on the ground, right? Understanding the baseline. As you move further up, diagnostic analytics allows you to sort of test hypothesis, identify key key metrics, do root cause analysis to try to understand why does it happen. So it might be identifying factors like patient age, wound type, interactions, or their biometrics, for example, to really understand what could have had significant impact on an adverse outcome. Let's say that adverse outcome in this instance is wound infection rate, because everyone has wounds. What we'd like to prevent is infection rates, right? Then you move on to that, and we move on to predictive analytics. So really trying to predict outcomes, what will happen. So that goes to talk about predicting risk of wound infections rates based on current data that you have available about that person, that patient, about care patterns, interactions, carers, health systems. It actually goes back to that sort of first to something that you were talking about at the outset about the need for interoperability in care systems or in healthcare or social care systems, because that then gives you a full view, end-to-end view of the data, and that's really important, almost the lifeblood of any robust AI use case. And then you move on to, influencing outcomes, right? Thinking about what are the recommending perhaps personalized care pathways or interventions that would allow you to avoid wound outcomes that you want to avoid. In this case, like I talked about, it would be sort of wound infection rate. I wanted to ground an example of this, ground this sort of continuum in this example of wound care. So to bring this to life, it's because I think most providers sit at the descriptive stage looking back at historical data, which in itself is valuable. You do want to understand what's going on, so you understand whether there's a problem or not. But the exciting shift is obviously moving towards prediction and recommendation, and that's what a lot of our efforts clearly are focused on. At Nourish, when we think about this being, this journey being practical and responsible, and not just sort of introducing AI for the sake of it, but actually being very thoughtful about use cases and value stories where AI can make a difference. Moving on to the next page, I'd like to talk about this concept of triple aim of social care. So triple aim is a concept that actually came in the U.S. healthcare, and then we at Nourish have adapted it for social care. This idea that good health or good outcomes for people really lies at the intersection of these three pillars: care quality, personal outcomes, and care operations. So you want to make sure that people
who receive care or who draw on care have sort of positive clinical and care outcomes. You want to make sure that their experiences are personalized, and then you want to make sure that the providers of care are able to run those care organizations efficiently while maintaining or improving quality, right? And none of these use cases or none of these pillars are really separate from each other. They're all interconnected, as you can imagine. So whenever we think about use cases, and this is what I would recommend people, whenever you think about use cases, do have a think about what is that impact to whether this pillar or whatever might be relevant for you, before you go on to think about, here's a nice use case, right? How does this impact, for us, the sort of the kind of view that we like to look at is, how does this impact care quality? How does this impact personal outcomes? How does it impact care operations for providers? So having a view of impact at the outset allows you to make sure that you're focusing on the right use cases. Your use cases have positive ROI, and you're actually having positive impact on care. A note at the bottom that I would like to sort of talk about is making sure that AI systems need to be designed and built with responsible AI in mind. Otherwise, we might talk about positive impact, efficiency, but unless they're built responsibly with fair principles and in mind, then they don't have the impact that we're looking for. And so the promise of AI in healthcare really sort of fails. I'll move on to now use cases. So I introduced the 3 pillars earlier. So I just have some exemplary use cases based on those pillars. Again, like I said earlier, there's immense potential in these data and AI-led use cases. One thing to note is the value really lies in scaled implementation. Some of the things I see is there's a trend of a lot of pilots, which is great. You need pilots to validate whether AI models work, whether use cases have value. But if you live in the pilot world for a long period of time, what that means is you're actually not getting the ROI that you're looking for. And so to me, unless use cases are actually implemented at scale, they don't bring the value. But going back to the use cases, I talked about care quality. Under care quality, health outcomes monitoring means using data to track trends across conditions, not just for one person, but across populations. Earlier, someone used the example of population health management, and that's exactly right. You might also look at sort of predicting modeling for care-specific sort of scenario, especially in elderly care, falls, infections, are sort of these avoidable adverse events that we want to avoid. Falls in particular cost the NHS, the British health system, an estimated of £4 billion a year, which is astronomical number. So it's very important to use data and AI to actually predict and prevent some of those risk factors. And intelligent auditing. Regulators and care providers have to go through auditing process here in England. I'm sure other health systems have to face the same. And that auditing itself is a huge burden. It's helpful because then it allows you to sort of sense check the care that's being delivered, but that auditing, the process of auditing, can be a huge burden. So using AI to sort of enable smarter auditing, whether that's through care plan auditing, using AI to actually identify issues in care plans, and sort of proactively surfacing them, or like physical auditing that might be around how a care home is run, for example. That's a care quality use case that I think is really high value as well. In care operations, looking at things like occupancy management, the day-to-day running of a care home, right? Looking at demand forecasting, so you're actually getting a good sense of how much how much supply of facilities do you have, rooms, beds, whatever that might be, versus how much care are you contract bound to deliver based on sort of people that you've taken on. That managing that fine balance of demand and supply of care needs allows you to be sort of efficient. And sort of forecasting and optimization techniques definitely help there. proactive maintenance, where the sort of can you use sort of predictive maintenance to identify any potential sort of facility related maintenance opportunities, and sort of avoid more unexpected sort of maintenance, right? In terms of personalized outcomes, being able to provide people who deliver on care and their families better visibility into sort of what's going on with their care, whether that's through personalized goals trackers, whether that's through family portals, whether that's through sort of activity scheduler and allowing them to sort of express their preference so that they're not just they're not receiving care, they're active sort of participants in their care. So that's some of the examples of use cases that I think are relevant in particularly with the lens of UK care sector. But I also want to leave you with this. I think the potential is immense, and use cases aren't, or coming up with the right use cases isn't the bottleneck, but actually implementation and scaled implementation can be a bottleneck. So to actually realize the immense potential, we need to build on a foundation of trust, good quality, and genuine partnership within care systems. The technology is changing rapidly, so it's more about whether we're ready to use it responsibly and meaningfully.
Thank you. And you know what? I know some people might want to comment, but can we wait until the after party, because we have one more use case to present? And joining us from Spain. Thank you so much, Suda. Do you mind staying for the after party?
Yeah, happy to.
I just realized I don't know how to pronounce your name.
Hi, how are you? Good afternoon, everyone. I am Sasha, and my background is biomedicine and technology management, and I have experience working in research, in startups, and in public health sector focused on digital health. So, may I start with the use case?
Yes.
Okay,
the floor is yours.
Thank you. So the use case I bring you today is not mine, but is one I think is really interesting for this webinar, and is early detection of Alzheimer's disease using retinal imaging analyzed with artificial intelligence. So Alzheimer's pathology begins 10 to 20 years before symptoms appear, and by the time memory loss is clinically evident, significant neurodegeneration has already occurred. Traditional biomarkers are not scalable for population-wide screening, but the retina offers a unique opportunity. From a developmental perspective, the retina is not just part of the eye, it is neural tissue, because during embryological development, it originates from the neural tube, the same structure that forms the brain. In other words, the retina is part of the central nervous system. And because of that, neurodegenerative processes affecting the brain may also produce measurable structural changes in the retina. So, using images already present in ophthalmology clinics like optical coherence tomography or fundus photography.
Sorry, Sahira.
Yes.
Can you show your slides?
Sorry, I don't have slides. I was reading the comments.
It looked like you were reading from slides, and there's a horrible noise in the background.
No, sorry. I didn't prepare slides. I was reading the comments, but I didn't prepare. So with these images, AI models can analyze structural and microvascular patterns, just like, for example, thinning the retinal nerve fiber layer, the reduction in ganglion cell layer thickness, and changes in the retinal mixed microvascular density. And artificial intelligence processes these images in a single forward pass and generates probabilistic risk score of early neurodegenerative change. Importantly, this is not a diagnosis, it is a risk stratification layer. This use case could sit in the clinical workflow during routine ophthalmology visits, and this AI could run in the background and analyze this image automatically. If a high-risk score is detected, the patient could be referred to a neurology for further evaluation. And this means we are not adding invasive procedures, we are leveraging existing infrastructure. And this is where the bigger transformation lies. This is not reactive healthcare waiting for cognitive decline to appear. This is preventive healthcare, detecting risk earlier, intervening sooner, potentially slowing progression, and reducing hospitalizations. But how could we integrate this innovation in the electronic healthcare record? So in the United States, the debate is about market dominance, while in Europe, the challenge is fragmentation. On one hand, in the United States, a small number of leading electronic health record companies control much of the clinical workflow. While some European countries have strong national vendors with significant market share, Europe as a whole faces fragmented systems, heterogeneous interoperability, and complex procurement structures. This increases the effort required to integrate across different electronic health record systems. So public European initiatives are focusing on increasing interoperability. For example, one of the initiatives promoted by the European Union is the European Health Data Space, which aims to establish a common framework for the secure exchange and reuse of electronic health data across member states. And particularly in Spain, there is a national initiative to create a unified electronic health record across autonomous communities. So rather than addressing vendor dominance, the challenge here is coordinating fragmented regional systems to enable secure data sharing and better clinical decision making. But we must not forget that the first stakeholders we need to convince to adopt innovative technologies are hospital professionals. If they clearly understand how these technologies can support their work, implementation process becomes much easier. Thank you so much for inviting me.
Thank you. Thank you. Can you stay for the after party?
Yes, I can stay a bit. Yes.
Thank you. We're starting we're wrapping up the webinar, and we've actually still got some more use cases to come. And I'm going to add Spotlight. And Anthony, I haven't forgotten about you.
No problem. No problem.
Are you ready to come on?
Yeah, I can. I'm a bit late, sorry, so I've missed some of the background context. But yeah, if you give me a steer on what you'd like, then absolutely.
I wonder if you can present us a use case in about 5 minutes. Can you give us the 5-minute version?
Yeah, sure. I've got loads, but I'll give the one that got me into this world and got me on the journey, the AI journey. So the background. Is it
Anthony Lawton?
Yes.
By the way, welcome. You're based in the UK, and you do a lot of work with strategic oversight and change management in the NHS. Have I done a good job of introducing?
Yeah, absolutely. I was just going to storm in and miss that bit out. So yeah, I've been in the public sector since 2007. I went in for 3 months, and I've never managed to get out since. Mainly the NHS. Once you get your work in there, it's hard to escape. Absolutely fantastic in many ways and very frustrating in others. And this frustration of this particular case was what really triggered me. I was working on a big menopause project, national project with NHS England. We needed a qualitative evaluation doing. Long story short, it cost £75,000 and took 9 months. And it was a real trigger for me, which was, my God, that is a long time and very expensive. So that really logged with me.
That is quick and cheap. Sorry.
No, absolutely, it can be. I mean, the standard for those national ones is 750,000, and we tried to do it cheap and fast and got to 75. So that was a real anchor for me. The second thing was another business case, national NHS England business case. I won't be too specific with it, but there was a big consultancy firm that had done the business case. On the back of that business case, it was a multi-million-pound pilot over 3 years, 6 regions. And I was called in to investigate why it wasn't working. So I went and spoke to about 10 nurses and got information from that ground level that was just missing at that big decision point. And again, long story short, I had that brain connection of, I believe my hypothesis was the guys at the top here making these multi-million-pound decisions are making them because they're not getting that ground level information, which will and should impact on those big major decisions. And I realized that the reason they're not doing that religiously and in a really robust way is because it takes so long and it costs so much. The third thing that finally did it was the book there. This was about 2.5 years ago. I'd written it, and somebody had said to me, Dame Barbara will do the foreword for you. So I'd reached out and I was waiting for a response. And in the meantime, I thought I'm using ChatGPT a lot at this point. I thought, right, I'll train the AI agent to study her style. I uploaded 55,000 words of the book and said, please write me a foreword in the style of Dame Barbara. And it blew me away. It was so good. It was really, really good. And this was 2.5 years ago. So things have got a lot better since then. So those three things came together, and I realized and I invested heavily from then on that these agents used properly can be industrial scale qualitative evaluation tools. So I've built a tool called Insight Genie. And essentially now, instead of senior managers doing their normal thing and writing a questionnaire, which is 35, 40 questions long, and it's death by survey, I've now got this system called Insight Genie, which is 3 questions, only 3 questions. And maybe in the after party, I'll stick to me 5 minutes. I'll give you some detail on these. But now it's beautifully simple. You speak to all your cohort, your stakeholders, and you say, we really want you to tell the truth. 3 very open questions. And the data you get back is insane. My record so far now is this was with a tech company. We met on the Thursday, discussed it like this, got into some detail. I designed it on the Friday. They signed it off Friday afternoon. It went to the stakeholders on Monday morning. It closed Friday evening. I'd done all the reporting by Tuesday. So we've got a 12-day complete start to finish timeline. And I'm not trying to sell it, but it's a fraction of the cost and 12 days instead of 9 months. And it's that sort of industrialization, if you use AI properly, that can completely transform. Because back to my trigger case study, if we'd have done this then, I swear to God, they would have saved multi-million pounds, because that original business case was not fit, because they just missed so many critical things that they would have pulled out had we done this work, really quickly. It would have really influenced the case. I've got a bunch of different tools and stories, but that's a founding one for me. That sort of changed my life.
Thank you. And